going to discuss is Veress needle. Veress needle was invented by one physician, his name was Veress. So, his idea was that there should be some instrument which can be introduced into the chest for pleural aspiration. So, that there will be a blunt tip. So, that after going into the space where the fluid is accumulated, the blunt tip will come in front and it will not damage the lung. That is how he has invented it. Veress needles are available in 4 sizes, that is 8 centimeter, 10 centimeter, 12 centimeter and 20 centimeter. 8 centimeter Veress needle is used for junior pediatric patients, like less than 5-year age group, you will use 8 centimeter. 10 centimeter and 12 centimeter is used for adult and 20 centimeter is used for senior pediatric patients. 20 centimeter is used for bariatric patient, that is for obese patients. For morbid obesity you will use 20 centimeter. So, 8, 10, 12 and 20. Now, Veress needle 10 and 12 for adult. If little overweight patient you will use 12, normal patient you will use 10, 20 for bariatric. Now, Veress needle, every instrument you have to learn 5 important property. One is name of different part of the instrument. Second is uses of that instrument. Third, you have to learn complication that instrument can do. Fourth, you have to learn what is the alternative of that instrument. Suppose I do not have it, then what I can do alternative. And fifth, how to clean and sterilize. This information is required for every instrument what we have. So, Veress needle has 2 parts, one is needle, other is a stylet. This is the needle and this is a stylet. A stylet has one eye at the tip, but this eye is not on the tip, it is on the side. The eye is on the side and tip is blunt. Tip is blunt. It has one spring here and one valve. This lock, if it is parallel to the stylet, that means it is open. If it is at right angle, that means it is closed. During introduction of the Veress needle, this knob should be open or closed? Open. So that if you enter into any vessel, immediately you will learn that I am in wrong place. Now, you have to hold it like a dart. This is the way to hold it, and that much portion should be naked, it should be naked, and how much you will use it depends upon the thickness of abdominal wall. So, by the side of umbilicus you should hold it like that. This is umbilicus and this is, suppose this is the patient I am holding. So, it is that much thick. If it is that much thick, you have to add further 4 centimeters. So, this is and further 4, I have to hold it like this. Why? When you put the Veress needle, it is chanting and then it punctures, and here it is chanting and then it punctures. So, this is chanting 4 centimeter and 4 centimeter. So, suppose patient is morbid obese and if you hold it like that, this self is 8 centimeter or 10 centimeter, then 10 plus 4, 14, and at least 4-5 centimeter is required to hold your 3 finger. That is why in morbid obese patient you are using 20 centimeter. Suppose this is pediatric patient and that much thin, then I have to hold it here if I am using in very thin patient. So, how much you will keep the tip of the needle free, this depends upon the thickness of the abdominal wall, 4 centimeter plus thickness of the abdominal wall, and then you will hold like a dart. Dart is a game which is used to throw. If you have to aim, you are using dart, and dart always they hold it like a pencil this way. If you will hold like that, you cannot throw it, you cannot get a aim. Holding like a dart has one more advantage, that your elevation angle will be 45 degree. During introduction of the varus needle, always tip of the varus needle should be pointed towards the anus, and it is this way you are pointing towards the anus, towards the anus of the patient. If you are pointing towards the anus, you have many advantages. One advantage, never ever in your life you will damage the aorta or vena cava, because aortoiliac axis is approximately 5 centimeter above the sacral promontory. So, just 5 centimeter above, aorta is bifurcated into common iliac vessels. So, there is no point I can damage the aorta or vena cava if I am pointing towards the anus. Second advantage is, if you are pointing towards the anus, you are going to the halosacral curve, and that area does not have the vertebral body. In the lumbar or thoracic vertebra, there is a vertebral body which is giving counter from below, like this, how it is elevated. But in the sacrum, the body of vertebra is in the same plane of transverse process. So, it is not elevated up, and it is curve, halosacral curve. So, it does not give you counter from below. Even if the varus needle goes, it can be dimpled in. Third advantage is, if you are going towards the anus, your vertical entry is 50% and your horizontal entry is 50%. Like this is called as vertical entry and this is called as horizontal entry. If you go perpendicular, your vertical entry is 100%, horizontal entry is 0. But if you go 45 degree angle, then your horizontal entry is 50% and vertical entry, horizontal shift is 50%, vertical shift is 50%. So, you will not touch the bowel. If you go completely perpendicular, your 100% is the vertical entry. So, you are going more deeper. Am I clear? So, these are the points you should point towards the anus, but there is a problem. If you are going the oblique, then 45 degree angle, this angle is 45 degree, then your vertical depth of entry is less, short, because half of the length is occupied in the horizontal shift, isn't it? So, that is why you are more away from the bowel, and that will prevent the injury of the bowel. But going towards the anus has a big problem. Problem is, there is a fair chance that you will go to preperitoneum, because going oblique, your tip of the varus needle will slip over the peritoneum. See, it is sliding, and if it is sliding like that, you will go somewhere in the preperitoneum and you will insufflate the gas there, isn't it? If it is prick, it is, you are lucky it is pricked, otherwise it is preperitoneum, and then a huge preperitoneal pocket will form. Your trocar also will go, your telescope also will go. With the telescope you will see fibrous trabeculae just like a spider web, no bowel is visible. That happens for the beginners. All of you might have gone couple of times to the preperitoneal space, because we are hesitant, especially the beginners, and you are going oblique. So, you go to the, this is a big problem. So, what to do? If I am going oblique, I am going to the preperitoneum. If I am going perpendicular, I am in risk. So, what to do? The better way is you should go oblique as well as perpendicular, both. So, what to do? You lift the abdominal wall in such a way that angle between the varus needle and abdominal wall is 90 degree, but angle between the varus needle and the body of the patient is 45 degree. So, your both the problems are solved. So, you should lift the abdominal wall a lot. If you cannot lift your own, you should ask the assistant for help. So, if you will lift it like that, then it is perpendicular, but it is oblique also. Oblique in relation to the body of the patient and perpendicular in relation to the abdominal wall of the patient. So, it will neither go to the preperitoneum nor it will touch the aorta or vena cava. That is why your anesthetist should give the maximum amount of muscle relaxant during the introduction of varus needle or trocar. Sometimes our anesthetists, they don't do so, they keep the patient light, because they think that right now surgery is not fully started. Once the patient will go in the deep surgery, then I will make it little deep. But this is actually wrong. In laparoscopy, maximum relaxation is required during the entry of the varus needle and trocar, and that must be carefully done.
Sorry, I missed someone.
Muscle relaxation.
The insertion point where?
Pardon?
The puncture or site where?
Puncture, I am not discussing the site. Site, why I am not discussing? That there are 5 sites of access. One is supraumbilical, infraumbilical, superior crease, inferior crease, and transumbilical. Puncture site and Palmer's point. Puncture site I will not discuss, because right now I am discussing only instrument.
Yeah, so
Puncture site I will discuss during a separate presentation what we have, that is called as access technique. Okay? At that time, yes, what is your question?
Whatever the side, it should be 45 degrees to the.
No, only in the umbilicus.
I'm asking you.
Yes, if it is Palmer's point, it should be perpendicular to the abdominal wall. Because Palmer's point, you are correct. If you point towards the anus, it will damage the splenic flexor of colon, isn't it?
But the anus means that you are going backward.
Pardon?
It means you are going backward.
No, you are not going backward. Do you know why? Because you have lifted the abdominal wall. So actually, in relation to the abdominal wall, you are perpendicular, and as soon as you leave it, you are perpendicular.
But now it is not towards the anus.
No,
You
no.
know, as a rectus point, it will be change it backward.
Yes, that's why only during the introduction, you will lift the abdominal wall so that the varus needle is pointing towards the anus. But in relation to the abdominal wall, it is perpendicular. Am I clear? Yes, tell me again, no problem.
We must see it practically.
Yes, practically I will show you. Practically I will show. Actually, we have already a lecture for that, access technique. In this video also I will show you. And all of you tomorrow morning, you have to practice it also. From tomorrow, the schedule will change actually. From tomorrow, 2 batches will be there. One batch will start at 9:30, and 9:30 to 12:30 you will have 9:30 to 12. 9:30 to 12 you have practical every day, and 12 to 1:30 there will be one lecture. 1:30 to 3 again 2 to 3 o'clock there will be second lecture, and the second batch will start from 12 o'clock. And from 12 to 3 o'clock they will attend the lecture same way, and from 3 to 5:30 they will have every day 5:30, or sometime if the lecture is little delayed you can do up to 6 o'clock. Every day there will be practical. So, the first batch will come at 9:30 and they will be free around 3 o'clock, and second batch will come at 12 o'clock and they will be free at 6 o'clock. Is it okay? So, this is the schedule from tomorrow. So, tomorrow morning the first session will be access technique, where all these dummies has the abdominal wall, and we will give you Ellis forceps, we will give you varus needle, and you have to do suction irrigation hanging drop test yourself, and you will introduce the varus needle and trocar. So, the idea is that up to the relation of the abdominal wall it should be 90 degree, and then it should be backward. Backward means
And my question for more orientation. This is the symphysis pubis, and this is the kephalate, and this is the caudal part.
yes.
Okay. The anus is like that, not like that, because the reflection of the rectus as the anorectal area is going backward, not going like that.
No, I am saying the anal opening. Yes, I am not giving you the my purpose is that wherever the anus opening is there, it should be pointed. Means if you don't consider the anus, at least consider this as a 45 degree. That's all. You know, because you are saying that anus is going backward. That is you true, but we are not talking about the passage of whole of the anus. I am talking about the anal opening. Means wherever we feel in the brain that where the anus is there. The idea is that you should escape the sacral promontory. You should not go perpendicular. You should escape the aorta. You should not go towards the vena cava and aorta. You got my point?
So this thickness, according to the thickness of the abdominal wall,
Yes.
this is 45 degree becomes 60 and then 90 as
No.
the obesity increases.
You know what happens sometime with the, there are 3 exceptions of oblique entry. One is morbid obese patient, another is any lower midline incision, and third is diagnostic laparoscopy under local anesthesia. Suppose patient is morbid obese, BMI 40 and all, then you do not have to go oblique, you should must go perpendicular. That you have told, because if morbid obese patient, if you will go oblique, you will be lost somewhere in the fat pad, preperitoneum, and in morbid obese patient we go transumbilical. If you are a gynecologist, and if you are a surgeon, sometime in morbid obese patient you have to go supraumbilical. Do you know why? With the morbid obesity, umbilicus displaced down. Like sometime if the patient is super morbid obese, like WWF, sumo and all, their umbilicus is up to the level of a scrotum, because it displays so much down. You see, they are holding with a cloth, they are supporting their abdominal wall. So, for those patients you may have to go supraumbilical. That is why in the bariatric surgery we do not consider umbilicus as a point of relevance, we consider from GP sternum. From GP sternum your port should be 20 centimeter below, and it depends now where it is. It may be 5 centimeter above the umbilicus, maybe 10 centimeter above the umbilicus, depending upon how much umbilicus is displaced. So, that is why we consider from GP sternum 20 centimeter below. But in those obese patients you will never go oblique. Oblique you can go only when you are going around the umbilicus. Otherwise, in the Palmer's point you will never go oblique, in supraumbilical you will never go oblique, isn't it? But 90% of the surgery is done going through the umbilicus. Umbilicus is the most attractive site for the primary trocar insertion. Reason being, it is central location, making the access of all the quadrant of the abdominal cavity easy, because central location. You can go right iliac fossa, left iliac fossa, upper hypochondrium, everywhere. Central location can give you the access of all the quadrant. Second advantage is it is the thinnest part of the abdominal wall, because at the level of the umbilicus, inferior and anterior and posterior rectus is fused together, which is making it thinner. Third advantage is it has a cell intelligence. There is a vitreointestinal duct that has a cell intelligence of a spontaneous closure. Do you know umbilicus is always open in the yes, after birth or in the fetus, but just after birth spontaneously it is closing, isn't it? Because of vitreointestinal tract, which has a cell intelligence that shrink its own. So, due to that we are talking about here umbilical entry. The other entry is exceptional entry, that I will discuss later. So, this should be perpendicular, and idea of going backward means idea is going towards the anus, and so that we should escape the great vessels. And after that, once the pneumoperitoneum is created and once abdominal wall is distended, automatically it becomes perpendicular. It is not like that if you are doing cholecystectomy, then you cannot put towards the anus, because once the abdomen is distended it will again become corrected and then trocar will sew you up, there is no problem in that. So, this was the how the varus needle we should hold. Now, second is as soon as it is in, you should do the irrigation, suction and hanging drop test. This is irrigation test, it should go free flow. Then you suck, when you suck nothing should come, same fluid which you have irrigated, if it is coming back, that means we are in the closed space, preperitoneum, maybe rectus, maybe subcutaneous. And if more fluid which you have irrigated is coming back, that means patient either has ascites or patient we are in the bladder, urinary bladder was distended. If red is coming in the vessel, if the yellow is coming in the bowel, then you should do hanging drop test. You should put few drop of saline and you will see a hanging drop here. This is hanging drop, and then lift the abdominal wall, it will be sucked in, because after lifting the abdominal wall, negative pressure of the abdominal cavity increases. Normally also there is a -2 to -4 millimeter of mercury negative pressure inside the abdomen, but if you lift it, it will be sucking it. If sometime if this drop is confused, you are confused that it is positive or negative, then you can do plunger test. In plunger test, the piston is taken out here, and then you will see this column will be sucked in. Can you see it is dropping slowly, and this column of the water is sucked in. If it is negative pressure, it is sucked very fast. If you are in pre-peritoneum, it will not be sucked, it will be here only, because a positive pressure is formed due to the fluid there, and then it will stop further going the plunger test. This is called as it is empty now, and these tests are used for the plunger test, PLUNDGER. Now, these are the tests. After that, you will start the pneumoperitoneum, and once the pneumoperitoneum is started, then there is one more test which is called as quadromanometric test. Quadro means 4, manometric means pressure test. Quadromanometric, yes.
What was those 3 tests? What was drop test?
Irrigation test, suction test, hanging drop test. Hanging drop test also can be replaced by plunger test, and then quadromanometric indicator. Quadromanometric indicator I can demonstrate you during the insufflated presentation. So, that I will separately discuss for how the quadromanometric indicators.
What we get to know from the first irrigation test?
You know, irrigation test has 2 advantages. One advantage that always the eye of the various needle is on the side. So, during introduction, once this blunt tip, this is blunt, this is not sharp. So, during introduction, once blunt comes in out, then the eye of the various needle sometime going there like this, see it will catch some of the soft tissue or fat. So, once you irrigate it, it get flushed out, and second, the irrigated fluid should not disappear. If irrigated fluid we could not take it back, that means we are inside the abdominal cavity. If the irrigated fluid is coming back, that means we are in the closed cavity, we are not in the abdomen. That is why irrigation is important, is not it? And in the suction, if the blood is coming, that is vessel, if it is yellow is coming, that means in bowel, and if it is fluid or a straw color is coming, that means either ascites, tubercular ascites or in the bladder. Sometime blood comes, if there is rupture ectopic suppose, and there is a hemoperitoneum, then blood also can come, but at that point we know that blood has to come, because it is already we know by ultrasound that 1 liter blood is inside the abdomen. So, this is how you have to do suction irrigation hanging drop. Now, the next question is, what are the uses of the varus needle? First use is very obvious, that is pneumoperitoneum. Second use may be sometime huge ovarian cyst is there. If you want to aspirate, you can go percutaneously, you can aspirate it, or maybe some dermoids. Yes. Yes, in cholecystectomy sometime if you want, you can use it, but basically we use aspiration needle. There is a separate needle for that. This is aspiration needle here, yes, that one, and it is better for cholecystectomy, isn't it? Here, this is aspiration needle, that will go, but if you want, you can use it. Yes, you can use that also, but this is aspiration needle, and here you will attach the suction and directly, but if you want, you can use it. You are absolutely correct. Now, other use, very good use is, it is a very fantastic port closure instrument. It can be used for port closure. How? You have to open it and remove the stylet and put a one suture into the varus needle. This is a varus needle, you take any suture. You can use nylon, you can use catgut, you can use PDS and introduce one suture. And after introducing the suture, here the suture is introduced. Can you see that? This is suture. And then tie a knot. Just tie a knot. Here knot is tightened, and then hide it. It is hidden and it is now made. After that, what you do? You take another suture, any suture, Vicryl, silk, PDS, whatever you want, and put inside this tip only 2 centimeter, and then bend it. It is bended. Now, hold it like a dart, and suppose this is a port. Go by the side of the port, leaving the skin, do not hold the skin, and rest of the layer you will puncture, and you are in under vision. all the port closure is done under vision. And then you put the finger over the longer thread and pull the smaller thread out. Here you are out, but still this tip is in. Now you go from other side and pull it. As soon as you pull, a loop is formed. Can you see a loop? There is a loop. And then just entangle this suture and pull this suture out, and it is out. And then tie the knot. It is done. See here. And then you tie both, and it is tightened. Port is closed.
It's for both sides bleeding. In case of
This is
bleeding
to
or
tighten
the
the opening.
Close the rectus and muscle and every layer together.
Close at the end of surgery, you mean? At the end of surgery?
At the end of the surgery,
You
yes.
mean port closure?
Port closure.
Instead of the end of lynch.
Yes.
Sir, in all cases,
Instead of the suture passer or there is another way. This is also used for 2-port cholecystectomy, 2-port appendicectomy or ventral hernia surgery to fix the transfacial fixation of the mesh in the ventral hernia. We use it for transfacial fixation. So, this is I will demonstrate you later also. If you put in the YouTube varus needle port closure, then you will see my videos there also. But right now I will just demonstrate you how to do. Again I will show you once more. You make a loop first like that, and then put one suture and put the 2 centimeter of this suture, only 2 centimeter inside this eye like that. That's all. And then hold it this way. And even if the cannula is there, cannula डाल दो तो उसमें, ट्रोकार डाल दो उसमें, वही एब्डोमिनल दे दो, येलो है वो दिखाई देगा. Even trocar डाल दो. Even if the trocar is there, you can close it. Go by the side and then introduce it in, and once it is in, then put the finger over the longer thread and then pull this out, and it is out. But this thread is already in. Then you go from other side and then you go in, and as soon as you pull it, see, can you see a loop is forming, and just entangle this suture in the loop and it is done. As soon as it will entangle, sometime you may take it out also, cannula you can take it out, and as soon as you entangle it will take it out. See here, this is suture itself is pulling the suture, and this suture is out, both the ends are out, and then you can tie the knot. You can tie the knot. Do you know this is very simple? It is done by the cobblers also, shoemakers, when they suture the. Yes, endoclinch has the advantage that you have to buy this. Like you have a different type of suture passer, Lauto. That is cobbler's needle, endoclinch, suture passer. There are different names which you can use. Suture passers are a small instrument which you can use for port closure, but varus needle also can be used if you do not have any sophisticated instrument. This is suture passer. Suture passer has only one drawback. If you are holding it, sometimes the jaw remain open, and while pushing it in, it breaks. In the Google, if you will type the suture passer and broken suture passer, there are 20 articles published which has been demonstrated that it breaks the suture passer while introducing it. But here it is impossible to break. Sometime it is used for the, this is suture passer. Suture passer, there is one a small eye. Can you see that? But there is a problem. Sometimes what happens that when you are holding this suture in this small eye like that, and if accidentally you will hold it by the base, accidentally if you will hold it by the base here like that, then it remains open. Can you see that? Here, if you will hold like this, this is open. Even I am not holding it open, and then if you will try to grow, it will break because it is entangled into the tissue. So, this is a risky instrument which sometimes is dangerous. So, the suture must come into the eye, and this suture passer is used to push it in and then pulling it out. It is already broken already, and then you will push it in, and after going it in, leave the suture and then come out and go from other side and again catch this and pull it. This is suture passer. but if you do not have, you can use Veress needle. It is also used for appendicectomy. Like suppose you have the sponge lana, this is appendix, and suppose you want to do 2-port appendicectomy. You do not want 3rd port. Not lap assisted. In lap assisted, you have to take appendix out, but here want 2-port. Then what you do? This is abdominal wall. In this abdominal wall, put the Veress needle, and then you go with one of the grasper and catch the appendix here this way, and then rotate the Veress needle. As soon as you will rotate the Veress needle, it will hold the appendix. You will see within few seconds it will start holding the appendix, because once it will rotate, a knot will form. और प्रेस करो थोड़ा सा. Very good. छोड़ दो. And then once this will go, then it will act as a traction. See here, and then suture itself is giving traction, and then with other grasper or harmonic, you can dissect the major appendix and you can separate it. Okay. So this way it can be used for other purposes also. For Veress needle, it is very simple. Just you have a same loop, this is a loop, just you go through the abdominal wall and pull the Veress needle, a loop is formed. Then through this loop a grasper will go and it will catch the tip of the appendix, and then yes, and then outside it will be rotated. Once you rotate, automatically just how a wrinkle will form here, and that will hold the appendix. See, it is holding the appendix, and then appendix is stretched like that. And level of stretch you can adjust by pulling the suture out or in, and then you can dissect the major appendix by the harmonic, and then you can tie one extracorporeal knot, and then you can cut the appendix. So how to do, we will learn later. Once I will discuss the appendicectomy, then I will demonstrate you many way of doing appendicectomy, and this is also one of the way. And do you know, this puncture of the needle will not leave any scar, and it is not a port because it is going percutaneously. So there is no any port required. Needle will require only the 1 millimeter prick of the skin with the 11 number knife, that is all. Just at the end you have to put some neosporin powder and a scab will form. No any stitch is required, no any handiplast also is not required, a steady strip is also not required. A scab will form which will dry within few seconds, isn't it? So these are the purposes of the Veress. Now next question, how to, yes?
Can we use the disposable Veress for this?
Disposable Veress, one Veress needle you have to break. So any old Veress needle you can break and you can remove the stylet out, then you can use it, because stylet is not used in this purpose, only the needle part is used. Now the next question is how to clean and sterilize. Laparoscopic instruments are basically never sterilized unless until you use the disposable. Laparoscopic instruments can only be disinfected, high level of disinfection you can do. If you want to disinfect it, you have the many options. One is glutaldehyde. Glutaldehyde is 2% glutaldehyde which is used. The trade name is Sidex. Sidex is very popular, but many names are there like gluterol, glutehyde. In India many companies are making. This is activator. This is activator. So you have to mix with this, and as soon as you mix, it is now start countdown starts, and it can be used for 15 day or 15 time, whatever comes earlier. There is one Sidex tray. In that tray you have to keep this instrument for 6 to 8 hours if you want to sterilize, and here you have to write the activation date and expiry date. It can be used once activated, it can be used 15 times or 15 days, whatever comes earlier. Like in 3 days you have 15 surgery, then you have to throw it out after 3 days. In 15 days there was no surgery, then also 16th day you cannot use the activator, it is now expired. Inside there is another tray, that is a perforated tray inside.
Excuse me sir, if you have kept it once, for how long you need to keep it?
15 days.
No,
No, there is
Okay. Contact time. Contact time is 6 to 8 hours if you want 100% sterilized. 6 to 8 hours. But if you want only bactericidal, then half an hour. The glutaldehyde is very good virucidal. Virus it kills within 30 seconds. It is a very good bactericidal also. Within 15 minutes to 20 minutes, maximum half an hour, it will kill the bacteria also. But it is a bad sporicidal. For a spore, it takes that much time, 6 to 8 hours. That's why nowadays glutaldehyde is less used. It has few drawback also, that sometime it has been known to be carcinogenic, especially for the nurses who are not wearing the gloves and repeatedly the glutaldehyde is touching the skin. Few cases of the skin cancer has been reported. So nowadays we are using the new generation chemicals. These are the biguanides para-aphthaldehyde solution. So it has advantage that you can use same way 15 day or 15 time, same way, but it does not have any carcinogenic. This is many names are there. This particular name is Medis. Medis is a trade name from elderly pharmaceutical. The Ethicon is selling it by the name of Rapicidex. Rapicidex.
Now, what's the
And
principle?
yes, principle is it contains the biguanides,
Biguanides.
biguanides and para-aphthaldehyde. This is not a single chemical, it is a compound. So it has an advantage that within 30 minutes it is sporicidal also. If you then the bactericidal 10 minutes. It is written here that immunocompromised tuberculosidal 30 minutes and HIV 30 minutes and a spore also 30 minutes, isn't it? So even the spore can be killed within 30 minutes with these solutions. The cost is more. In the glutaldehyde it will cost you approximately 500 rupees for 5 liters. But this one you have to mix with the 450 cc of the 4500 cc of saline and then it will be activated. And the cost of this one is approximately 2500 rupees. So it is approximately 5 times expensive. But it is safe and quick, especially for a high volume hospital where in one day you have 5-6 surgeries. You don't have that much 6-hour time to give contact time. And you may not have those many sets of instruments. If you have 4-5 sets of instruments, then it is okay. One instrument in one, another. But if you have only a single set of instruments, you should use biguanide solution. You should not use chilled forceps to lift the laparoscopic instrument, otherwise insulation will break. And then you are in trouble because it can create the burn to the intestine, insulation failure. So always gloves hand will be used to lift. If you don't want to waste 5 liters further saline to wash it out, sometimes what we do that 8-9 instruments your nurse can hold like that, and with one single 500 ml saline bottle, they just drip it out and rinse it out. And then you can keep on the instrument charge. If you don't want to waste. But ideally, there should be 2 side extray, in one saline, in another glutaldehyde, then lift it and rinse it in the other side extray and then you put it. So that outside glutaldehyde should be completely washed out. Although if little is attached, nothing happens. So this is regarding the sterilization process. Another way is you can use formalin chamber. Once the instruments are sterilized, and suppose your surgery is cancelled or your surgery is next day, then you can use formalin chamber. This formalin chamber outside you will not touch. She will touch. This I am not supposed to hold because my hand is gloves. And inside she will not touch. Your gloves hands should touch, and then telescope, the cables, then hysteroscopes, and then the different type of electrodes, camera head, all you can put in the side X-ray. And glutaldehyde, this is formalin chamber. And these are the formalin tablets. These tablets, 6 tablets you have to put in a moist gauze piece, and it is only active till it is tablet form. Right now it is tablet. Once it is become powder, that means it is expired. You have to use another. how frequently you have to change it depending upon how frequently you are opening it. Also depend upon the temperature, ambient temperature. If it is winter, these tablets last for 2 weeks also. But if it is summer and your OT is not fully air conditioned, then it may be within 2-3 days and frequently you are opening, then tablet become powder. Tablet comes like this and then you will take it out and inside these are the formalin tablets. So this is also one of the way. Formalin tablets should be ideally used to keep the instrument sterile. It should not be used for primary disinfection. But at some places they use it for primary disinfection. If you are using it for primary disinfection, at least overnight it has to be cleaned. Like in the evening, if you will clean the instrument with the alcohol, with the spirit outside. First you clean with the rinsing water with the detergent, then clean with the alcohol, then dry it, and then put it in the formalin chamber in the evening today, so that tomorrow morning you can perform the surgery. And in spite of not using the butadiene, some people directly use formalin chamber. Ideally, formalin chamber is used for keeping the instrument sterilized or carrying it from one place to another place. Like if you are a freelancer performing surgery in 2-3 operation theatres, in 2-3 hospitals, and you want to carry your own instrument, then for that formalin chamber is useful. Other way of disinfection is ethylene oxide chamber. Ethylene oxide chambers are little expensive, but 55 degrees centigrade for half an hour if you will use, your instrument is nicely sterilized. Another way is gamma chamber. Gamma chambers are only available in very sophisticated high-end hospitals. Generally, we don't prefer gamma chamber, and in India, we don't use gamma chamber for these instruments because cost will be so high. 40 lakh rupees is the cost of the chamber itself. Cost will be so high that if that much money if you will use, then better is to use disposable. Disposables are cheaper because if you will see the interest of that much money, 40 lakh rupees, then you can use the disposable and you can charge the patient also. That's why disposable, but disposable if you are using only if you are rich. If you are rich, you use disposable. If you are poor, then you should use reusable. But if you are using disposable as a reusable, that means you are very poor. Disposables should never ever be reused because disposables are made for single use. We have seen that many people they buy disposable and they don't throw it till it works. Either choka and cannula or instrument. That is dangerous because disposable cannot be dismantled, and those are instruments not made for disinfection because you cannot clean them. You cannot dismantle and clean them. So the blood, the pus cell, all is inside the disposable instruments. So it should never be reused. It is risky. It is strictly written that not for second use. Just like syringe. This syringe you will never reuse. Now, next instrument I am going to discuss is trocar.
Doctor, you have said that with this material you are disinfected the instrument, not sterilize it.
Do you know in the bottle itself it is written high level disinfectant? It is not sterilization. Sterilization word means each and every microorganism should be treated. Do you know? No, sterilized word we use, that is a misnomer. All these are disinfectant. If you will see on the bottle itself, it is written high level disinfectant. It is written there. Company they themselves they know. Do you know why? Sterilization you have to use autoclaving. The autoclaving is possible with these instruments. But the problem is each instrument should be separately wrapped. Because if instrument will hit like that, it will break the insulation. And if you will keep every instrument together in autoclaving, and then you heat it at 130 degrees centigrade at 22 Pascal pressure, then if it will touch one instrument, another insulation will. So each and every instrument has to be wrapped with a separate polythene pack which comes. It's a polythene wrap over instruments. I will show you and then you can autoclave. But if you autoclave, it is sterilized. But if you are thinking that I am using only chemical and sterilization means it is guaranteed, general. Do you know why? If you are putting in the silex tray, suppose little bit that much is also out, then that portion is not sterile, and it can make the other parts infected. That's the reason nowadays spore producing organism infection is increasing in number, especially atypical mycobacterial infection. Do you know why? Because in high volume operation theatre, and especially in the operation theatre where the same theatre they share for open surgery as well as laparoscopy. Same theatre they share. Suppose they did one laparotomy, they did one delivery in the same OT, they did wound burn infection and sting grafting in same OT, and then now the instruments are kept there, and then you are not giving proper sporicidal 6 to 8 hour contact time. And suppose you did appendicectomy in one patient and that patient has a tuberculosis, intestinal Cox abdomen, and then the same instrument you put in the sidex and within 30 minutes other patient is ready. And now the transfer of atypical mycobacteria to one patient can happen. And these spore producing organism infection is a lot. All over the world it is panic, and sometimes the wound that creates the weeping like this. Because patient will come and they will say that I have the discharge. Whenever they go to the shower, they press it, some fluid comes out. You will do the culture sensitivity test, nothing comes. It will come sterile. And then later it will found that it is atypical mycobacterial. Now you have to give high dose of clarithromycin together with the or4 drug regime of the tuberculosis for 12 months at least, then it gets corrected. And then also if you recognize late and the intra-port side, sometimes sinuses form. That will one port will communicate with another, will communicate with the third. And then you have to do the extensive debridement and surgery to treat it. So that's why in the developed country they don't use these reusable instruments at all. They use entire set of lab poly kit or other kits. If you will give one lab poly kit, I will tell you, this is the one lab poly kit which Ethicon is making. It is fully sterilized, autoclave with the complete disposable gamma ray radiation. So it is guaranteed. Now once you will cost is 75,000 rupees. Once you will open it, this is on your instrument trolley. It has 3 tiers. In one you have the 4 trocars, one varus needle. These are disposable varus needle, which I will demonstrate you later, but just because just to demonstrate you. Here this is second level. In second level, one seizure, one grasper, one Maryland. And third level, one automatic clips here, loaded, preloaded automatic clips, and this is one another Maryland. So this is all is coming in one pack, and cost is 75,000 rupees for one lab poly kit. So here it is new, and sterilization is guaranteed, and you don't have any problem of any infection or any breach into the sterilization. But the problem is that it cannot be, every patient cannot afford. 75,000 means approximately $121,200, and that much cost every patient cannot afford. So you have to use a reusable instrument, and if you are using it, then take care of the proper sterilization. Sterilization and cleaning both are separately important. Cleaning is also important. I will show you later how to clean. Once I will come to the instrument. Now the second instrument which I am discussing today is the trocar and cannula. This is trocar and this is cannula. Although it is used as a synonym, your consultant will always tell that give me trocar. If you are asking for trocar, give only this. Don't use this. The trocar means this only. This is cannula. All together both is called as port. This is 10 millimeter port, this is 5 millimeter ports. And ports has 2 tips, one is trocar, another is cannula. Trocar has one eye at the tip. There is one eye, which eye is communicated with the back. Can you see there is one hole here? This is the eye. There is one eye. This is communicated. This is to give hissing sign. As soon as trocar enters, the gas started leaking from there. This is called as hissing sign or hissing sign. This hissing sign is very useful. And trocars are of many types. These are called as pyramidal shaped trocar. This is conical trocar. This is safety trocar. This is pyramidal shaped trocar, and there is a blunt trocar. There are different types of trocars out there. conical trocar, it has only cone. This is blunt. This is safety. Safety means it has a spring loaded, and these are the different types. But most popularly used trocar is the pyramidal shape trocar, because do you know why? Due to the pyramid like shape, once you go and keep on rotating, it displaces the tissue, rectus and muscle. It only punctures the peritoneum. The skin anyway you are cutting by the knife. So, skin is cut and peritoneum is punctured. The rest of the layers are only separated, so that chances of hernia is minimum. And these, pardon? Sheath, rectus sheath, fibers are there, so it is splitted, but it is, you are not cutting with the knife. So, the advantage is that bladed trocar will cut it, but pyramidal will split it. So, you have to hold it like that. Of course, little injury is always there, but compared to bladed trocar, very less. Now, you will hold it like that, and the head, and this is cannula, and cannula has a two part, one is valve, another is shaft. This is the shaft of the cannula, this is valve of the cannula. It is very important. Open the flap, and then your cannula is not opened. Cannula, your valve has to be opened, and then yes, inside. No, not that. That is washer. This is on the top. This is called washer. Seal is inside. Yes, no, in the valve. Yes, inside the valve there is a seal. Here. Yes, that one. Can you see the surrounding? Yes, that one, exactly. This is a rubber seal. This rubber seal should not be broken. If it is broken, you have to change it. Otherwise, gas will is giving you rubbery sound. See, this is a beautiful sound. If it comes metallic sound, that means it is broken. So, there are two type of seal. One is called as valve seal, another is called as washer. This washer is on the top. This is also replaceable part, which time to time you have to change. This is washer on the top. This is also a type of seal, and this is the valve. There are few valve which has a magnetic valve. Magnetic valves, this is called as flap valve. This is magnetic valve. Inside there is a magnet. Here, if you will see that, this is magnetic valve. Here it is, and it is attracting the magnet there. Can you see? So, once it will go, it will open, and it is closing. This is magnetic valve. Magnetic valves are also present, also useful, but only problem is sometime during cleaning your nurse can miss the magnetic, and magnetic force are not very strong force. So, sometime blood clots or fat get deposited in between the magnet and the seal, and then gas keep on leaking. So, it is less popular, people are not using much. Maximum number of the companies, even the stores and all, they make flap valve, which is opening and closing. Now,
So you are saying what a hissing sound that comes from this?
yes, this that is communicated with the back, and when you are attaching it, you have to hold the trocar, port, trocar and cannula like a pistol. This is the way how to hold the trocar. Head of the trocar should rest over the thenar eminence. Middle finger should go around the air inlet of cannula, and index finger should be pointed towards the sharp end. This is the way. Head of the trocar should rest over the thenar eminence. Middle finger should wrap around the air inlet, and index finger should be pointed towards the sharp end. This is the way how to hold the trocar, so that the pressure over the thenar eminence and middle finger should counter each other. Do you know, if you will not keep it like that, then if you will push it, the trocar comes back, and with the cannula you are struggling, nothing happens. So, the thenar eminence and middle finger should press each other. This is important, and index finger should be halfway reaching there. So, that suppose you are putting the like that, if you are going into this sponge suppose, and you are going there, it will stop you going inadvertently. You should rotate it, and then it will stop you halfway. You got my point? So, keep it there, do not push it, just keep it there and keep on rotating your hand, and automatically it will drill, and then it is stopped. So, that inadvertently you will not pierce the trocar into the aorta or vena cava or bowel. Remember, trocar and cannula should always go perpendicular, it should not be pointed towards the anus, it should go perpendicular to the abdominal wall. Do you know why? Because pneumoperitoneum is already maintained now. This is already it is there. So you should go perpendicular.
Sometimes there is bowel.
This is just to check the sound, and at the end, suppose you want to remove the gas, you can use it. At the end of the surgery.
Yeah.
Yes.
It's like this and
Then gas will come out.
Otherwise, gas isn't.
Yes. Now other important thing is that in the old, pardon? Like this, yes. Like this, index finger is here and index finger is pointing towards the sharp end, middle finger is wrapping the cannula. Do you know in old books there is one textbook of Kathodia. Kathodia was a very famous surgeon who has written the first textbook of laparoscopy. In Kathodia textbook what was described that inside you should go like a jet technique. Jet technique means you should go first this way, then you go that way, and then again you go this way. So Kathodia has described it that skin is here, then you go like that, then you go like that, then you go like that. So skin opening is here and peritoneum opening is there. Advantage is as soon as you will take the trocar out, all the layer will overlap each other and there will no hernia. Yes, that was very good idea, but it has a lot of problems. One problem is during making a jet shape, you will lacerate a lot of vessels. There is chances of subcutaneous hematoma. Other problem is when you retrieve the organ, abdominal wall will ask for some share. Like if you want to take appendix out, then abdominal wall will try to catch some of the major appendix because it is trying to lock. You got my point? And during locking it will tear some of the fat. And those foreign body in the abdominal wall can create abscess formation. And last problem is there is undue force over your cannula. See here. You know why? Because it is entry and exit point is separate. So there is undue force over your cannula. And forcefully if you will try to turn the cannula to the other direction, it will be teared. And once the peritoneum is teared, there is a lot of pre-peritoneal sagging and even the subcutaneous emphysema. Surgical emphysema like. So that's why it is nowadays it is not recommended. Always whenever you have to put the trocar and cannula, go perpendicular to the abdominal wall. Wherever, suppose it is here, you go like that. If it is here, you go like that. If it is here, you go like that. And perpendicular to the abdominal wall. As soon as the tip of the trocar is anchored, now you can change the direction. So that it is perpendicular. And if it is perpendicular, there is no force. You can move in any direction. There will be absolutely no force on your movement. And see, even I am moving, there is no tear in the peritoneum. So that's why perpendicular we should put the trocar and cannula. And always under measure.
But
Now,
the primary trocar which we have to do that should
no, that also perpendicular. Perpendicular. Do you know why we are using? There are few questions. From your question, there are few questions which is there. There are few articles published where they have demonstrated that varus needle is not required. We can directly put the trocar. And according to those articles, primary trocar has a less injury than the varus needle. And if you will see in the camps in the India for sterilization camps, they put the trocar directly. They never use varus needle. That is called as direct trocar. And there are few articles which is published which say that direct trocar insertion has less injury. Varus needle creates more injury. And it is true. Varus needle being sharp and pointed, it creates more injury. Trocar, if you will directly without varus needle directly, if you put the trocar, the number of incidents of the injury is less. But it is half truth. Next truth, half of the truth which is not discussed in those articles is that majority of the injury by the varus needle goes unnoticed. And none of the injury done by the trocar can be unnoticed. Varus needle when being sharp and so pointed like a needle, many a time it punctures the body. Many times it punctures the omental vessel, mesenteric vessels. But because it is needle, so little hematoma forms, it stops. Bowel, even if it is punctured, varus needle is out and bowel automatically seal. You never know also that it was there any time. That's why the injury of the varus is still safe. That's why we are using varus needle. We are using varus needle to prevent the injury of trocar. isn't it? So that a space is formed between the bowel and abdominal wall, so that trocar should not do the injury, because trocar injury can never be unnoticed. If you do not want to use varus needle, then you use Hassan's technique. Hassan's technique is a open technique that is used. Person has a 2 to 4%, but all these 2 to 4% will develop into the peritonitis, generalized peritonitis, bacterial peritonitis. So that's why blind trocar surgery you should not learn. You should not. The people who are doing for years, the people who are very much habituated, let them do. Let them do. You may see some people they never use varus needle, they always put direct trocar. If they are doing, let them do, but we should not use it because it is not under the guideline. Yes. Yes, always. For the primary one. For the primary one also, it should must go perpendicular. And this is guarded. Yes, under control. Suppose little bit you can lift the abdominal wall, although lifting the abdominal wall in the distended abdominal wall is not easy. But if you can lift it little bit, a little angle you can give. But you will not be able to point it towards the anus. You will not be able to do that. And if you will do that, you will go to pre-peritoneal. Because it is now already distended. So always the trocar should go perpendicular. Always trocar should, and guarded by the index finger. And you should never push the trocar. Let it go by its own, by rotating movement. Keep on rotating and take your time, and it is healed smoothly. Do you know injury happens due to momentum, and momentum is mass into velocity. Like suppose this is bowel, and if I am smoothly rotating going, if bowel comes, it will displace because there is no momentum. But if I am going like that, it will come. So most common cause of injury is abrupt forceful injury. Just like because speed is mass is velocity. Velocity is increased, injury will happen. If you want to explore the bowel, then 3 port may be required and minimum 2. So definition of diagnostic laparoscopy is, it is a visual examination and interpretation of the intra-abdominal organ in order to detect any pathology by 2 ports. If you are using only single port like telescope only, then it is called as peritoneoscopy. Means you are just seeing the peritoneal cavity. You cannot sweep the bowel away. You cannot lift the tube. You cannot see the posterior wall of ovary. Sometimes even you cannot see the appendix, because appendix is hidden by the small bowel. You cannot sweep the bowel away. So for diagnostic laparoscopy 2 ports are required. For operative, at least 3. Do you know even in the single incision laparoscopic surgery, incision is 1, but port is 3. So 3 ports are required, one for left hand, another for right hand. Now question is, how many 10 mm and how many 5 mm?
At least once would be 10 mm. At least once would be 10 mm and others.
At least, question answer is at least one should be 10 mm. Why?
2 10 mm.
He is saying 2 10 mm for tissue retrieval. Yes, for tissue. Yes, you are also correct. Do you know if you have a 5 mm telescope, then even the only one 10 mm will do, because at the time of tissue retrieval we will put 5 mm telescope in 5 mm port and 10 mm we will use to retrieve the tissue. But suppose you do not have any 10 mm, then you have to use the 2 10 mm. You do not have 5 mm telescope, then you have to use 2 10 mm. Some people they do the reverse feeding, that is not recommended. What is reverse feeding? Suppose this is appendix and they have only one cannula. Then what they do, they catch it like that, this way the appendix, and then they, suppose this is the telescope, they tell the assistant, okay, pull the telescope back, and assistant is pulling the telescope and they are pushing the appendix in like that.
We are doing this in gallbladder.
You are doing in gallbladder this? In gallbladder how come?
Reloading through the umbilical cord.
No, umbilical port,
We are taking the gallbladder through the umbilical cord.
and seeing from where?
And seeing through the camera.
Seeing through the?
We are gradually withdrawing the camera. At the same time, we are reloading the gallbladder through the bore and going out slowly until coming out.
Why not? So your epigastric port is 5 mm.
The 5, yeah, all 5 except the
Epigastric you are using 5 mm port. Okay. If you are using epigastric 5 mm, then you can use. but it has one problem. Do you know why? Because the instrument has taken already 5 mm and only 5 mm is left for your effective. So, when you are entering it, sometime it can tear. It can tear, it can puncture the gallbladder, a lot of bile can drop inside, and because you are not seeing, so you are thinking it does not happen. Do you know why? Because your telescope, once you are railroading, your telescope is seeing into the cannula only. And it is not seeing all the bile or all the infected material which has been dropped inside. And then when you contaminate the port wound also, and wound infection is one of the cause, and one of the reason is the way how he has done. This is one of the reason of that. So, that is why we should not use it. Idea.
The recommendation now is not to use the board as retriever for the organ. You should come into the pouch.
Yes, you
Not
should.
in cases of adenocarcinoma.
Yes, yes, absolutely correct. That is the reason Americans, and even in the whenever you have a doubt, even in the developing country, you should use endo bag. You should use endo bag, because even the normal looking gallbladder has a chances of carcinoma, and that can be due the port side metastasis. And you know, port side metastasis is a medico legal negligence. If you have port side metastasis, our patient can sue us. That because it is already published that it is due to not using the endo bag. Not only that, sometime if you will do the dermoid cyst surgery, and if you have not used a good quality endo bag, then there is a chances of squamous cell carcinoma of the port wound due to the dermoid cyst, because those content of the dermoid, if it will touch the abdominal wall, it can create a problem. So, these are some of the complications which we should must keep in mind and we should avoid. So, now sometime if you have a 10 mm, you will like to reduce that to the 5 mm. So, in those situations you have to use reducer, otherwise gas will leak. So, suppose this is 10 mm and if I will use 5 mm instrument, then gas is leaking, because valve is open now. With the valve open, I remember one thing, that suppose you are doing surgery, and if your pneumoperitoneum is lost, gas is not retaining into the abdomen, and abdomen is deflating, you do not have a working space, then where are the possibility of leak of the gas?
Around the wound.
Around the wound. He is absolutely correct, means your size of skin incision is big and it is leaking. How you will know?
You can put some saline drops.
Some saline drop you put and you can see the bubbles coming out. Very good. Another possibility?
Maybe from the washer itself.
Maybe washer. Another is valve. Another is valve. This is valve inside. Seal of the valve. So, how you will know that seal of the valve is leaking or the washer is leaking? Pardon? No, changing, so all you have to change 8. Suppose 4 ports are there, and change washer, 1 washer, 1 seal, 2. 2 from 4 you will change 8, that will take 80 minutes time. Changing will take time. Do you know, you remove the instrument, and after removing the instrument from any port, if the gas is leaking after removing the instrument, that means valve is defective, and if the gas is leaking after putting the instrument in, that means washer is defective, because if the instrument is in, then there is no role of valve, because valve is open anyway. So, at that time gas is protected by washer. So, after instrument insertion, if abdomen is deflating, that means washer is defective, and without instrument, if abdomen is deflating, once the instrument is not there, then washer does not have any role. Now, the gas is protected by the valve. So, without instrument, if abdomen is deflating, that means valve is defective. No, not port, just open the valve and change from the other port. Of course, you can change entire, but why you will put it out? Just keep it in and remove it and replace from the another. Or do not remove the instrument any time, always keep one instrument inside this. You got my point? Always keep the instrument there. That instrument you don't, and if you have to change the instrument, you may have to put a thumb and then change the instrument. These technical things happens always. during surgery. Some of the valve is leaking, some of the washer is leaking, especially for these reusables, because any time any of the ports should be defective. So, you should be able to identify and then take care of the leak. Now, reducers are two types. One is top mounted, this is top mounted. So, that if I want to make 5 mm, just I will put and it is done 5 mm. Another type of reducer is long reducer, this is long reducer, this is long reducer, which you can put in. Now, which one is good? Top is good, top loaded is good, okay. Long is good, okay. Why?
Because when you insert the long one, the valve keeps open.
Yes, that is true. And why this one? It can be easily applied. Both of you are correct. But both has its own merit and demerit also. Demerit of this one is, he is correct, valve is open. So, it cannot be introduced alone. It has to go with the instrument and come with the instrument. Like hold it and put 1/3 of instrument in, then hold both together and then you go in. If you have to come out, you cannot take the instrument alone. All the gas, abdomen will deflate. So, if you have to take it out, take 2/3 out, hold both together and bring out. But this is more useful. Do you know why? It can be used for tissue retrieval. It can be used for knotting and suturing. Suppose you have to retrieve a small tissue out. I do not want to make the port out and I do not want to use endo bag. Then I can use reducer, because if I will take the entire port out, what will happen? Abdominal wall will be in the contact. Suppose this is appendix and I do not want to infect the abdominal wall with this appendix. Then what is the better? I use reducer and hide the appendix in the reducer and then take it out, and this is appendix inside and I can exit it. So, and this has never touched anything. There was no railroading, there was no any pulling of the cannula, there was no touch of the appendix with the abdominal wall, isn't it? So, it can be used as a tissue retrieval. Sometime I have to put a needle inside for suturing knotting. This cannot be used. If I will use top mounted reducer, I cannot put a needle holder. Suppose there is a needle holder and I want suturing, and if I will hold it like that, I cannot go. See, it will touch, it is trapped here, it cannot go. But if I have a long reducer, I can put my needle holder first into the reducer like this, then I can catch the suture, then I can hide the suture, and then I can hold both together, and then I can go, it will not be trapped by the valve also, and then I can perform suturing knotting. Again, at the time of removing the needle, I will hide the needle into the reducer and then come out. Without reducer, if I will try to take it by the top mounted and I am going there, and if I am holding the suture and I am trying to take it out, see, the suture is trapped by the valve and it may break. There was one very funny article, but interesting, that they have lost the needle and for 6 hours with the C-arm they have tried to find it out. Ultimately, one resident has seen this was in the cannula. It was broken, yes, and they did laparotomy and with the C-arm for 6 hours, needle, where needle is gone, and needle was in the cannula. In cannula, C-arm also cannot see because it is metal. So, this is one of the possibility. Always keep in mind that not using the long reducer and trying directly taking into the cannula, it can break from here, and if you will see here, it is in the valve. See, it is trapped in the valve here, and it is lost. So, this is not good. Always use a long reducer. For needle, for suturing knotting, these are knot pushers. Van Darger knot pusher, Clark knot pusher. So, for suturing knotting, long reducer. But if you have to use only for instrumentation, like then use top mounted, because long reducer has a go with the instrument, come with the instrument. Here it is not bypassing the valve. So, in spite of being attached, gas will not leak because valve is still working, and then I can use the instrument 5 mm, and I can take this 5 mm out, again I can use another 5 mm, isn't it? And if I have to use 10 mm, I can do like that, and I can use 10 mm, and it is hanging there waiting for me. Again for 5 mm I can. So, both has its own importance, advantage and disadvantage, but long reducer can, if you have, you do not need short. You can do without, but without long reducer you have a difficulty in suturing, knotting or tissue retrieval.